Hello, and welcome to the DSERA Clinical Education Oncology Podcast. I'm your host, Ryan Topping. Today's episode features Dr. Jeremy Abramson of the Harvard Medical School and Mass General Brigham Cancer Center in Boston, Massachusetts, as he provides expert perspectives on key studies in lymphomas and CLL from the 2025 ASH annual meeting, including CLL-17 and BRUIN CLL-314 and 313. This episode is part of a larger educational program titled Bridging Discoveries to Practice, CCO's Conference to Clinic highlights from the 2025 ASH annual meeting. For more information, along with a link to the larger education program, please visit the show notes for this episode. Now, let's get started and hear what Dr. Abramson has to say about this important topic.
We've just completed a very exciting annual meeting of the American Society of Hematology with some very relevant and potentially practice-changing and practice-informing data that was presented across the spectrum of B-cell lymphomas and CLL. One exciting presentation was actually the very first presentation in the plenary session. And it was the presentation from the German CLL study group of the CLL-17 trial. The CLL-17 trial was a randomized trial with 3 arms, comparing ibrutinib monotherapy to venetoclax obinutuzumab or venetoclax ibrutinib. The ibrutinib arm in the study was continuous therapy, as typically done with a single-agent BTK inhibitor, whereas the venetoclax obinutuzumab and venetoclax ibrutinib arms were both time-limited therapies. And today, we don't have any direct data comparing these two strategies until now. These study results were important. Importantly, they showed that patients in all 3 studied arms did very well, with high response rates in all 3 arms. If we look at depth of response, the MRD undetectable rate, defined as 10 to the negative 4th, was highest in the venetoclax obinutuzumab arm, followed by venetoclax ibrutinib, followed by ibrutinib. The primary endpoint of the study was progression-free survival, and this was a non-inferiority trial to show that these agents administered in time-limited therapy were not inferior to ibrutinib given as continuous therapy. And that primary endpoint was met. There was no difference in 3-year progression-free survival, which was 80% approximately in all 3 arms. And what these data show is that time-limited therapy with either venetoclax or ibrutinib venetoclax were not inferior to continuous therapy with ibrutinib alone. Notably, the combination of venetoclax with a BTK inhibitor had also previously been studied with venetoclax in combination with acalabrutinib in the AMPLIFY trial. Now, the AMPLIFY trial did not include an arm for venetoclax obinutuzumab, so these particular data help support that either a time-limited approach with venetoclax obinutuzumab or venetoclax with a single BTK inhibitor, either ibrutinib per CLL-17 or acalabrutinib per AMPLIFY, are reasonable and appropriate and, importantly, highly effective and well-tolerated time-limited strategies. There were also additional CLL studies, particularly looking at the non-covalent BTK inhibitor, pirtobrutinib. As of today, in frontline therapy, patients can receive a BTK inhibitor with one of the fully FDA-approved covalent BTK inhibitors, ibrutinib, acalabrutinib, or zanubrutinib, with most providers preferring acalabrutinib or zanubrutinib, the next-generation covalent BTK inhibitors, due to a more favorable safety profile compared to the first-generation ibrutinib. However, until today, there were no frontline pirtobrutinib trials comparing pirtobrutinib with a covalent BTK inhibitor. At this meeting, we saw the first phase 3 trial doing just that. And it was a non-inferiority trial evaluating the non-covalent BTK inhibitor pirtobrutinib with the covalent first-generation BTK inhibitor ibrutinib. This was a non-inferiority trial designed to show that pirtobrutinib was not inferior to ibrutinib, but hopefully with less toxicity. As a matter of fact, however, the study actually appeared to show that pirtobrutinib appeared even more effective than ibrutinib. The overall response rate favored pirtobrutinib at 87% compared to 78.5%, and the 18-month progression-free survival was 87% for pirtobrutinib and 82% for ibrutinib. So clearly, pirtobrutinib was not inferior to ibrutinib in terms of progression-free survival. And in fact, pirtobrutinib was associated with a 43% reduction in risk of progression or death over ibrutinib. Now, not surprisingly, pirtobrutinib did have a more favorable safety profile. It was particularly notable that there were fewer dose reductions or dose discontinuations on the pirtobrutinib arm. And additionally, there were a significantly lower incidence of atrial fibrillation and other cardiac adverse events on pirtobrutinib compared with ibrutinib. And so these data would suggest, at least in the frontline setting, that we shouldn't be using ibrutinib as initial therapy. And these data would suggest that pirtobrutinib might be added to our upfront treatment paradigm options, along with acalabrutinib and zanubrutinib, if selecting a continuous BTK inhibitor strategy for our patients. An additional randomized trial evaluated the non-covalent BTK pirtobrutinib versus bendamustine rituximab in patients with treatment-naive chronic lymphocytic leukemia. As with many randomized trials that have come before this study, which have shown superiority of novel agents over chemoimmunotherapy, so too was the case here, with pirtobrutinib showing substantially better efficacy than BR in previously untreated CLL patients. The 24-month progression-free survival for pirtobrutinib was 93%, compared with 71% for BR, which correlates with an 80% reduction in risk of progression or death favoring pirtobrutinib. Now, if we turn our attention to tolerance, I'll note that there were more infections in the pirtobrutinib arm, and that likely reflects the fact that pirtobrutinib in this study was given as continuous therapy rather than time-limited therapy with chemoimmunotherapy. And so there's a longer exposure to drug therapy. I'll note, importantly, as well, that there was no difference in the incidence of atrial fibrillation, highlighting that pirtobrutinib as a next-generation non-covalent BTK inhibitor has less atrial fibrillation than the first-generation covalent BTK inhibitors that have come before. And these data, along with the data presented at this meeting of pirtobrutinib versus ibrutinib in previously untreated CLL, highlight pirtobrutinib, a non-covalent BTK inhibitor, as a promising upfront treatment strategy for patients with previously untreated CLL when selecting a continuous BTK inhibition strategy. If we turn our attention to follicular lymphoma, the standard of care for many patients with follicular lymphoma has really been similar now for several years. Patients with high tumor burden symptomatic follicular lymphoma typically receive chemoimmunotherapy in the frontline setting, and patients needing second-line management for follicular lymphoma have most often received the lenalidomide rituximab regimen. Now, more recently, we've had two randomized trials that have looked at a triplet with rituximab lenalidomide compared to rituximab lenalidomide alone. Previously, and at the last ASH meeting, we saw data for the addition of tafasitamab to rituximab lenalidomide, showing superiority of adding that anti-CD19 monoclonal antibody. At this ASH meeting, we saw results of the EPCOR follicular lymphoma, or FL1 study. And the EPCOR FL1 study compared standard rituximab lenalidomide to the triplet of rituximab lenalidomide plus the anti-CD20 CD3 bispecific antibody epcoritamab. Patients in both arms received time-limited therapy with either R squared alone or R squared plus epcoritamab. And importantly, this study showed a fairly impressive improvement in efficacy favoring the inclusion of the bispecific antibody. Patients on R-squared epcoritamab achieved a CR in 83% of cases compared to 50% with R-squared alone. And this correlated to a 16-month progression-free survival of nearly 86% for R-squared epcoritamab compared to only 40% on R-squared alone, which is a nearly 80% reduction in risk of progression or death, favoring epcoritamab R-squared over R-squared alone. These are the first data in follicular lymphoma that bring bispecific antibody therapy into the second-line treatment for follicular lymphoma and show that it can be done with superb efficacy. The side effects of this approach show that when you add epcoritamab, you do add some side effects related to the bispecific antibody, notably the low risk of cytokine release syndrome, which is quite manageable, along with more immune suppression, B-cell depletion, and hypogammaglobulinemia. But this is consistent with the known side effects of the relevant drugs that are included, with no new or amplified toxicity signal, and thus have resulted in a new, highly effective second-line follicular lymphoma regimen with R-squared epcoritamab. And then finally, I'll highlight one additional bispecific antibody story, and that's in relapsed refractory diffuse large B-cell lymphoma. I presented 3-year follow-up data of the STARGLO trial, which is a randomized trial evaluating the addition of the CD20-CD3 bispecific antibody glofitamab to gemcitabine oxaliplatin compared to R-GemOx. This randomized trial was conducted in second-line and later diffuse large B-cell lymphoma patients who were considered ineligible or without access to autologous stem cell transplant. Now, with 3 years of follow-up, we see ongoing marked benefit for glofitamab GemOx over R-GemOx, with a median progression-free survival of 14 months compared to only 3 months, and a median overall survival of 26 months for glofitamab GemOx, compared with only 13 months of overall survival for R-GemOx. At this meeting, we broke out the second-line patients who represented 63% of patients on the STARGLO trial, and the results were even more impressive. Among second-line DLBCL patients not eligible for transplant, we see a median progression-free survival of 20.4 months compared to 5.5 months for R-GemOx. The median overall survival has not been reached for second-line glofit GemOx patients compared to 14 months for R-GemOx. And at 3 years, the progression-free survival rate was nearly 42% for glofit GemOx treated patients compared to only 26% on R-GemOx patients. And at 3 years, we do see a plateau on the survival curve, suggesting that approximately 40% of patients treated with an off-the-shelf bispecific antibody regimen like glofit GemOx might in fact be cured. And these are patients who may not be able to travel or have access to either stem cell transplant or CAR T-cell therapy, thus potentially widening the availability for curative intent, highly active immunotherapy regimens for second-line DLBCL.
Thank you, Dr. Abramson, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Bridging Discoveries to Practice, CCO's Conference to Clinic highlights from the 2025 ASH annual meeting, please click the link in the show notes. And be sure to check back regularly for more episodes on important DSERA clinical education oncology podcast topics.